Great, thank you very much. Thanks, Dr. Salazar and Dr. Coe for the kind invitation to chat with you. I think we've heard a lot about what we can do with stents and how we can improve placement of stents and management of these, but certainly I think it's really important to think about what happens after the stents are put in. And we've heard some talks this morning and earlier this afternoon that point us in that direction as well. So I have no disclosures, but I do need to tell you that these are my views and not the views of my employer, who's the US government. Here are my acknowledgments. These are folks that I've had long conversations with and some slides from them over the last 10 years that have helped frame my thinking about medical management. So we heard earlier today that from Dr. Wasson that there isn't always a lot of great prospective data about how we want to manage venous stents after the stents are put in. And so, as she said, when you can't find prospective data, you start looking for retrospective data. And so there certainly are a lot more studies here, and based on these studies, there are now almost as many meta-analyses that are describing the results of these retrospective studies. And so there's a paucity of data here, but I think it's important to note that from this, we can at least separate out the causes of failure and why some of these might happen. Certainly in your practice, you've seen that thrombotic indications for placing a venous stent tend to have a lower primary patency than those that are non-thrombotic, than the nivels. And when we think about causes of stent failure, there certainly is the primary mechanism, which is again thrombotic or non-thrombotic, some procedural aspects, and as Minaj and Stephen just mentioned, inflow appears to be the primary driver here of whether stents will remain patent or fail. But then there are also some patient-specific factors. What else is happening with the patient? Do they have underlying CKD or another hypercoagulable condition? Is there pregnancy, as we heard about before lunch, that might modify this as well? And we know that when these stents are placed, the highest risk of stent failure, in particular thrombotic failure, is in the first 6 months. And it really almost doesn't matter whether you're anticoagulated or not. Both of those will demonstrate the highest risk of failure in the first 6 months. And there may be differences based on whether you anticoagulate or not, but regardless, in each of those groups, if it's going to fail, it's most likely going to fail in the first 6 months. And then after that, you start to see decrement in terms of risk. And so here on the left, what you'll see from the same meta-analysis are the different types of anticoagulation therapies that were used in this particular meta-analysis. And what you're seeing is a whole lot of different versions of this. And it's because the authors draw this really nice conclusion that there's a lot of heterogeneity in treatment plans, the inability to confidently assign varying disease states or treatment plans to an anticoag regimen. Therefore, you can't draw any conclusions from this. So what's in our antithrombotic toolkit? What are the different options that they've used and others have used? And so the things I think about are, how do you choose which one you want to? Is it a one-size-fits-all, or should we be thinking about the disease biology different as affecting your choice? Does patient preference make a difference? The patients have tell us frequently, I'm just not going to do INR testing. I'm just not going to give myself shots. And so how do you start to negotiate that or navigate that as you interact with your patients? What's the clinical scenario and the drug specifics? Are there differences in renal or hepatic impairment that might make a difference here? And then we've already talked a little bit about flow dynamics, the location of the stent, the length of the intervention itself. How good is your inflow? Is the stent apposition against the vessel, the vein wall, adequate or inadequate? And so we think about then what we want to choose. And so there's lots of options here. On the left, you've got the anticoagulants. So these are heparinoids. These are injectables. The oral vitamin K antagonists, DOACs, and then direct thrombin inhibitors. On the right, we have the antiplatelet agents, and you've seen all of these: aspirin, P2Y12 inhibitors. I'm a cardiologist, so I got to push a little bit further and say PAR1 inhibitors are on this list. 2B3A inhibitors fall on this, and those are administered parenterally as well. And so I asked myself, well, what do all the smart experts do? And so this is a great survey that was published a few years ago, and it shows that, well, there really isn't a whole lot of agreement. And so as Raghu Kaluri mentioned earlier, just before lunch, in any field, as we're tackling any disease, we should have some minimal level of agreement of what we're going to be able to give our patients to try and improve their care, and then everything else we can add on top of it. But here what you've got is heterogeneous antithrombotic plans. At least 10 different types of regimens of management of this antithrombotics, and less than 30% consensus in how we want to do this among the experts. This was a survey that was sent to experts, again, not to general practitioners. These are folks who've thought about this and really pay close attention to it. And so among these, again, we've got DOACs, low molecular weight heparins, and a number of other things as well. So let's think about what low molecular weight heparins do. So when we give low molecular weight heparins to patients after an acute DVT, and we want to look at whether or not there's differences in post-thrombotic syndrome, we know that the low molecular weight heparins have a reduction in the amount of venous ulcer prevention. There is also improved recanalization with them. And so there may be more venous competence with these low molecular weight heparins versus vitamin K antagonists. When you think about what happens after venous stenting, at least in this series, there's suggestion that you may have higher primary patency with low molecular weight heparins. There are risk factors for thrombosis, hypercoagulable states, really lots of different occlusions, and then low duration of low molecular weight heparin therapy immediately after. And importantly in this study, antiplatelets didn't affect the outcomes. But wait, there's more. So here's another study now that looks at antiplatelets after PTS intervention. In acute DVT, if you add antiplatelets to other anticoagulants, and in particular if you start to add 2 antiplatelets, you might actually reduce the amount of symptoms that you see afterward, or reduce the amount of recurrent stent thrombosis. And certainly there seems to be a difference here on the right as well. Anticoagulants plus an antiplatelet at the top had higher primary patency than the no antiplatelets. I like this nice study from Kaluri's group at Ohio Health. This is real-world data. They compared DOACs versus non-DOACs in patients over almost a decade or so, and found that there may be a primary patency that's very similar between these two groups, but in their practice, 90% are also on antiplatelets, and there was frequent loss of follow-up. So pointing us again to the need for more studies that inform this. So as a physician scientist, I think a lot about thrombosis as a thromboinflammatory problem, and so that where these inflammation and coagulation systems closely interact with one another. And as I start to step back and I look at these antithrombotics, many of them have anti-inflammatory properties. We know low molecular weight heparins do a whole bunch of stuff. They suppress cytokines, they reduce neutrophil activation, they reduce leukocyte activation and adhesion as well. Antiplatelets do a lot of the same things as well. And on DOACs, the jury's still out, but there may be some evidence pointing in this direction. As a cardiologist, again, I'm contractually obligated to make a pitch for statins. So statins have pleiotropic vascular benefits. We know that they reduce mortality, and they reduce recurrent VTE as well, and may even be helpful in patients who are off anticoagulation in reducing the recurrence of thrombosis. And what happens in venous stent patency? Well, it's a complete black box, or yellow box. We don't really know, and so there's room for improvement here. So what do the experts do in clinic? We don't agree. What do I do in clinic? Well, I think on this panel there's some consensus. As Mitch Soler just mentioned, early anticoagulation, perhaps with the low molecular weight heparin, is ideal. You might want to add an antiplatelet to that. Over a period of time, you can start to pare that down to a DOAC, maybe with a single antiplatelet agent. And then once you reach that conditional phase of being able to not have recurrent thrombosis, you might want to extend it to be able to use only a single antithrombotic agent. So I'll stop here and just make a plug for needing more data. This is a nice paper that was led by Minaj that discusses what the priorities are to be able to try and establish that minimal level of evidence, to be able to establish a minimal level of treatment for these patients that we can then build on. Thanks, and I'll stop here.